Welcome to AETCM, the emergency medicine channel. Today, let us discuss about hypoglycemia and management of hypoglycemic episode in emergency room. Glycemia means sugar. Hypo means low. So this is low sugar. So hypoglycemia is a clinical syndrome. It is characterized by low plasma sugar level. Mostly we do this with fingertip glucometer. So low plasma glucose level. Symptomatic sympathetic nervous system stimulation, that means tachycardia, sweating, anxiety, fear, palpitation, that is sympathetic nervous system activation. That's a warning sign for the patient. But what happens in patients who are on beta blockers, when the patient is on beta blocker for hypertension, they may not develop this symptomatic sympathetic nervous system stimulation clinical finding. So they can have hypoglycemia unawareness. That means their awareness about hypoglycemia is controlled or masked by beta blockers. So hypoglycemia with sympathetic nervous system stimulation and CNS dysfunction. That is mostly patient will go to coma. When the sugars are very low, patient will develop coma. So hypoglycemic coma. So hypoglycemic episode is mostly due to treatment, especially insulin or sulfonylurea. Normally patients who are on insulin, when they are not taking adequate food, both sulfonylurea and insulin, when they are taking adequate food, or sometimes what happens is patient who is having renal failure. Normally insulin is excreted out through the kidneys. When the patient develops renal failure, that means creatinine is increasing, this insulin will not be excreted out through the kidneys. So they, on regular dose itself, they started developing hypoglycemic episode. So in that type of patients, we have to reduce the dose of insulin. But if normal settings, if the patient has taken insulin or sulfonylurea tablet, that is an oral hypoglycemic agent, and if they don't take food at correct time, they can develop hypoglycemic episode. Reactive hypoglycemia is due to gastrectomy. That is, when the patient undergone gastrectomy, when the food reaches the stomach, naturally insulin will be secreted to the circulation, but the absorption of the sugar is not occurring because of the gastrectomy. In that case, patient develops reactive hypoglycemia. Pseudo hypoglycemia occurs due to processing of blood samples in untreated test tubes is delayed, and cells like RBCs and leukocytes consume glucose. So if you keep the blood for a longer period, sometimes hypoglycemia can be detected, but actually patient does not have any hypoglycemia. So immediately you have to process the sample, or we can go for fingertip glucometer, that will give faster results. Now another term is spontaneous hypoglycemia. We already have seen in the last slide that patient who is on insulin or on oral hypoglycemic agents, they can develop hypoglycemia. That is the normal process. But if the patient is not on OHA, not on insulin, suddenly if the patient develops hypoglycemia, this is called as spontaneous hypoglycemia. So spontaneous hypoglycemia can be due to, mostly in emergency room, it is due to sepsis. So sepsis is the most important factor for hypoglycemia in emergency room. Otherwise, alcohol can produce hyperglycemia, and afterwards patient can lead to hypoglycemia. Malaria can produce hypoglycemia because malarial parasite utilizes glucose, and the drugs like quinine, they can induce pancreatic secretion of insulin. So they are secretagogues like sulfonylureas, they can produce hypoglycemia. So quinine and malaria both can produce hypoglycemia. Quinine is a drug used in malarial treatment. Disopyramide, gatifloxin, salicylates all can produce hypoglycemia. Non-islet cell tumors like pancreatic tumors, insulinoma is one of the important differential diagnosis for hypoglycemic, spontaneous hypoglycemia. Hypopituitarism, primary adrenocortical failure, all can produce hypoglycemia. So in any spontaneous hypoglycemia, any young patient or elderly individual coming with hypoglycemia who is not on insulin or not on oral like insulin or oral hypoglycemic agents, and they don't have malaria, alcoholism, sepsis, not on quinine, salicylates, gatifloxin, always remember to take serum insulin level to rule out insulinoma. So during the hypoglycemic episode, normally the insulin levels are low in human body, but if the insulin levels are high and if the patient develops hypoglycemia, then that shows towards insulinoma. That's a differential diagnosis. Now, if the patient is having hypoglycemia spontaneously, then always try to take serum cortisol also. Hypoglycemia and counter-regulatory hormone, that is very important. Insulin try to reduce the glucose level, but all other hormones like glucagon, growth hormone, cortisol, epinephrine, all will try to increase the blood sugar. So insulin always try to reduce the blood sugar. Other hormones, they are counter-regulatory hormones, they try to increase the blood sugar. That's why after an hypoglycemic episode, these patients can have these patients can have a reactive type of hyperglycemia. Like normally, when the patient is having hypoglycemic episode, after 1 or 2 hours, sudden surge in blood sugar you can observe. So that is a problem. Like in the some patients, night time, if you give more insulin, early morning around 2 o'clock, 3 o'clock, they develop hypoglycemic episode. But after that, these counter-regulatory hormones act and they have a high surge in the morning blood sugar. We can read about Somagi phenomenon and Downs phenomenon. One is hypoglycemic hyperglycemia. After hypoglycemia, patient develops hyperglycemia. Other one is hypoglycemia and hypoglycemia. So these are the two problems in when we are treating diabetes. Early morning, if the sugars are very high, like around 6 o'clock, 7 o'clock, if the sugars are very high, you have to check the nighttime blood sugar value. Around 2 o'clock, 3 o'clock, you can check the blood sugar value. If it is very high, then morning hours you can have a hyperglycemia because of that itself. Suppose if the patient is having hypoglycemia around 2 o'clock, 3 o'clock, that is hypoglycemic episode, then counter regulatory hormones work and morning time you can get a very high blood sugar. In that case, you have to reduce the evening dose of the blood sugar. That we are not discussing now, just I discussed in a few sentences about that. And glucagon, catecholamines like noradrenaline we give in our clinical practice in hypertension, cortisol, that is steroids. That's why any patient who is having chronic steroid injection, they develop hyperglycemia, growth hormones, all are counter-regulatory hormone. So one of the drug like glucagon can be utilized for the treatment of hypoglycemic episode. So that is very important, but these drugs are very costly. Even cortisol also can be tried if the patient is having associated hypotension with hypoglycemia. Now, this is the two important mechanisms of insulin and glucagon. Just opposite side, insulin tried to reduce the blood sugar, glucagon tried to increase the blood sugar. That is a major difference. So, when we are giving insulin, patient develops hypoglycemia. If you are giving glucagon, patient blood sugars will increase. So in a hypoglycemic episode, this will be one of the important drug which can increase the blood sugar. The same drug is used in beta blocker toxicity also. Glucagon is one of the drug of choice in beta blocker toxicity. Now, symptoms of hypoglycemia, that is very important. We have seen that neurogenic symptoms or sympathetic overactivity, adrenergic overactivity. Patient develops sweating, palpitation, tachycardia, tremors, anxiety. So these are the 5 symptoms of hypoglycemia. But if you give if the patient is on beta blocker, just imagine if the patient is on beta blocker can control the palpitation, tachycardia, tremors, anxiety, everything. So these patients normally when a patient develops hypoglycemia, they detect hypoglycemia by these symptoms. So when before the onset of severe hypoglycemia, patient develops palpitation, tachycardia, sweating, all these things. But if the patient is on beta blocker, all these symptoms will be masked. Suddenly patient will go to hypoglycemic episode. So that is hypoglycemia unawareness. Neuroglycopenic symptoms like central nervous system can produce some problem because of the reduced glucose supply to brain. Patient can have dizziness, headache, clouding of vision, confusion, behavior abnormalities and confusion. Adrenergic symptoms are mainly seen in rapid onset of hypoglycemia, and neuroglycopenic symptoms are seen in progressive hypoglycemia. So this is earliest finding. The first finding will be neurogenic finding. Second finding will be neuroglycopenic finding. Now, hypoglycemia unawareness, we have already seen that patients on beta blockers, all these findings will be masked. Other than that, selective serotonin reuptake inhibitors like SSRIs, they used in treatment of depression can also produce this hypoglycemia unawareness. Nocturnal hypoglycemia means during the night time patient develops hypoglycemia. Patient can have night sweats, poor quality of sleep, hangover like features in the morning hours, severe headache, chronic fatigue, nightmares, restlessness, muscle twitching, all these things can occur. So many patients who normally we give insulin morning one dose and evening one dose. So morning 8 o'clock we give, evening 8 o'clock we will give, and night time, since it is a long acting insulin, night time it will cover. Most of the time this long acting insulin given in the night time will cover. Around 2 o'clock patient develops hypoglycemia. Some patients develop hypoglycemia. So blood sugar may fall less than 50. So during that time the patient develops all nocturnal hypoglycemic symptoms. But what happens here, counter regulatory hormones act. So 2 o'clock he develops, and 3 to 8 that early morning hours, counter regulatory hormones act and blood sugar increases. Unfortunately, when we check the morning blood sugar, it may be 300. So for example, it may be 300. So normal tendency is to increase the night dose. Instead of 8, next day doctors may give 12 or 15, thinking that morning sugars are not controlled. But it is actually, the fact is reverse. It is hypoglycemic hyperglycemia. So you have to take a proper history, and 2 a.m. blood sugar you have to check. If the blood sugars are very low, actually you have to reduce the dose of insulin from 8 to 6 or reduce the dose. So that is nocturnal hypoglycemia. Now there is a triad in insulinoma. So these patients can have increased insulin secretion. Normally blood sugar in our blood sugars are increased, insulin will be secreted. But here insulin will be secreted on any time irrespective of the blood sugar values. So even when the patient is having hypoglycemia also, patient can have high blood sugars. So these patients can have symptoms of hypoglycemia that we have seen. Hypoglycemia on lab investigation, symptoms are there. Then relief of symptoms following ingestion of glucose or IV glucose, when we give, the symptoms are released. So this is called as Whipple's triad. This is classically a feature of insulinoma. Now, whenever we treat a patient who is having hypoglycemia, we always check the we always check the blood sugar with a glucometer. We have to give a bold prick. Try to give a bold prick on the fingertips. Clean the area like what is given here. Give a bold prick. Don't try to squeeze too much. When you are squeezing too much, the blood sugar value will alter. Even if you take normal procedure, most of the glucometers can have 15%, up to 15% error. It can go high or go low. Okay. So clinical features are very, very important. Now, some patients with hypoglycemia, you can see that sugars may be 60 or 70 or 80. That may be an error because 15% error are known in glucometer. And every time you have to calibrate the glucometer properly to get an accurate value. So these things you should remember. Bold prick, then use a good glucometer. Always think about this 15% error and correlate with the clinical finding. Serum insulin level should be taken in all patients who is having spontaneous hypoglycemia. So in insulinoma, during hypoglycemic episode, insulin levels may be high. In a normal hypoglycemia, if you are giving insulin, then insulin levels no need to check, it will be high. But in spontaneous hypoglycemia, because of the insulinoma, insulin will be over secreted and patient blood sugars are very low, but insulin levels may be high. So all insulinoma patients had a higher value of C-peptide, that is a precursor of insulin, and all normal subjects who were hypoglycemia level have a lower values. So C-peptide is another important investigation in hypoglycemia, but routinely we don't do C-peptide. When you think about, when you have a doubt about all these things, you can check it, because if C-peptide levels are high, then then the insulinoma is secreting insulin. If C-peptide levels are low, then there is no insulinoma like that. Even if you give an external insulin, C-peptide will not be altered. But insulin levels will not be utilized for patients who is having hypoglycemia due to a condition like insulin induced hypoglycemia, or sulfonylurea induced hypoglycemia, or quinine induced hypoglycemia. Their C-peptide will not be altered. Now, when we have a patient who is having hypoglycemia, we always try to take care of his airway, breathing, circulation, because most of these patients GCS will be very low. GCS will be very low. Normally, we have a tendency to intubate the patient if the GCS is less than 7. But in hypoglycemic episode, we no need to intubate the patient. We give the dextrose, patient will become normal. IV dextrose can be given, 50 ml, 50% dextrose can be given. In children, IV dextrose 0.2 mg per kg can be given. But remember, most of these patients will respond immediately. But patient who is on sulfonylureas or long-acting insulin, or patient is having insulin with renal failure, all these patients can have initial hyperglycemia, then suddenly their sugars will be repeatedly going hypo episodes. So these type of patients, we have to continuously give dextrose infusion. You can start 5% dextrose infusion in all these patients. If the patient is very sick and if we are not having time to like control other, like suppose the patient is having other clinical features also, it is better to give a glucagon 1 mg IV. Remember, but it is costlier than routine treatment. Glucagon can be, if it is available, can be given to the patient so that it will act fast. But immediate treatment is always dextrose. And we already discussed that sulfonylurea caused hypoglycemia can be recurrent. So we have to give continuous, you give 50% or 25% dextrose initially, then switch the patient on 5% dextrose or DNS, and that has to be continued for at least 24 hours, because sulfonylurea action time may be maximum 24 hours to 36 hours. So we have to be very careful. Now, in a hospitalized patient, we have already seen all these things. You take care of patient's airway, breathing, circulation. If the patient is able to take proper diet, you can give fruit juice, bread, milk with sugar, biscuits, all these things. If the patient is not able to take anything, you give dextrose 50%, then 5% or 10% dextrose fluid can be given continuously. And you can give injection glucagon in all patients who is having hypoglycemic episode. So you can give glucagon and reverse the insulin levels or reverse the hypoglycemia levels. But remember, glucagon is very costly. So we don't recommend that in routine treatment in our country. But standard guidelines say that we can give. It is available in most of the emergency room nowadays. Now, we should remember the differences between hypoglycemia and hyperglycemia. I'm not going to all the differentiating features because these are basics. One of the important differentiating feature we should know in emergency room is pH. If the patient is having hypoglycemia, normal hypoglycemia, there is nothing can be changed in pH in a normal patient who is having hypoglycemia because of insulin or something. But if the patient is having hyperglycemia and if the patient is having diabetic ketoacidosis, they can have all features of ketoacidosis, that is acidosis. Patient can have Kussmaul's breath sounds, sorry, Kussmaul's breathing, and patient can have low pH, that is acidosis. Ketones can be present in urine. So all these things are there. But it is very difficult to clinically diagnose between hypoglycemia and hyperglycemia, even when we tell all these things. You have to check the blood sugar values. That is the easiest thing nowadays. It is available everywhere. So you check the blood sugar immediately, and remember there is a 15% error in all the glucometers, possible 15% error because of the faulty techniques. So that has to be taken care of. So we have discussed about hypoglycemia in emergency room. So hypoglycemia is a common phenomenon in emergency room. Many patients can come with hypoglycemia. Our duty is to make out whether this hypoglycemia is due to diabetic drugs or non-diabetic conditions or spontaneous hypoglycemia. So in a patient who is having is not having diabetes, and if he develops hypoglycemia, remember to take one investigation, that is serum insulin levels. C-peptide also can be tried to take immediately. You can take draw the sample and you can check it. So hypoglycemic episodes are very, very common, and we can treat it very easily with dextrose infusion. But the problem is prolonged hypoglycemia can kill the neuronal cells. So prolonged hypoglycemia can produce central nervous system dysfunction, and it will be difficult to resuscitate that type of patients in emergency room. So immediately the bystander or the doctor who is attending the patient should act, and they have to take care of the insulin level. At least give a glucagon injection. If you are not able to put an IV line and give dextrose infusion, give a glucagon injection, IM or whatever it is, you can give it, and at least try to improve the counter regulatory hormones and develop hyperglycemia immediately. Thank you.